Hi, I'm Jared Gardner, and I'm here today with my fellow Ed Fulton, and Ed selected some nice cases of vasculitis for us to review today. The topic of cutaneous vasculitis is really complicated and broad. There's a lot of different types of vasculitis that can present in the skin, and some of them have systemic involvement and some do not. And so I think both from the rheumatology perspective and from the dermatopathology perspective, these can be pretty complicated and challenging. So we're going to just review a handful of different cases today. It certainly won't be comprehensive. And there's a really nice paper by Andrew Carlson from Histopathology 2010. I'll put the link down below in the video description in the comments. And it really has a very nice way of looking at the different types of vasculitis and kind of subdividing them by pattern and by whether or not they have systemic involvement. And Andrew's written a lot of really great stuff on vasculitis, and not just that paper, other ones as well. So I'll put that down there that you can use as a reference. So the first thing is to recognize what is leukocytoclastic vasculitis. Well, that's basically vasculitis, damage of the vessels, that is mediated by neutrophils. So it's neutrophilic vasculitis. And it's a relatively common thing that we see in the skin. And a lot of times when we see LCV, or leukocytoclastic vasculitis, we abbreviate it LCV. When we see that in the skin, a lot of times it's just localized to the skin and it doesn't have systemic involvement. But we always like to notify the dermatologists, and especially if there are some particular features, which we'll talk about in a minute, and then they can decide if there's any clinical or any systemic involvement, and they can work them up clinically and with additional laboratory testing as needed. So when the key from low power, I think, is whenever you see clusters of what look like neutrophils clustered in the dermis like this, you have to, from low power, you right away should think of leukocytoclastic vasculitis. And also, if you see a lot of hemorrhage in the dermis, you should instantly think, could this be vasculitis? And then go down closer for inspection. And in this case, even from here on 10x objective, we can see that this is going to be a nice example of leukocytoclastic vasculitis. When we go closer up, you might wonder, well, where is the vessel? And that's actually kind of problematic in well-developed LCV. The vessel can get so damaged that it's kind of hard to see where it was. But you can see right here a little ring of endothelial cells. So that's the lumen of a vessel. Over here, there's a little lumen of a vessel there with a little red blood cell inside of it. And what's happening is that around the outside of the vessel, let's go down one higher power here and see if we can get it in focus. Around the outside of the vessel, you're seeing a bunch of inflammatory cells, and most of them are neutrophils. Sorry, still trying to focus here. There we go. Mostly neutrophils, and a lot of the neutrophils are breaking down into tiny little nuclear particles, nuclear debris. So we call this process leukocytoclastic, that the neutrophils surround the vessel, and in damaging the vessel, they break down into karyorectic nuclear debris. So that's one feature, is to see neutrophils around the vessels, and another feature is to see the presence of debris, and the third feature is to see damage of the vessel wall. And that can kind of come in the form, in the two forms, either fibrin in the vessel wall and or necrosis. And sometimes it's hard to tell fibrin and necrosis apart, and so we use terms like fibrinoid necrosis of the vessel wall to describe that. But all this pink material that's kind of amorphous that you're seeing here in between the neutrophils wrapping around the vessel, that's fibrin. So fibrin deposition in the wall of a vessel, I find that really useful, as well as the nuclear debris. Now, sometimes you have more or less of these features. Sometimes you'll have neutrophils around vessel, but you won't really have debris or fibrin. In that setting, you have to be a little careful to not overcall something as leukocytoclastic vasculitis, because anytime you have neutrophils that are coming into the skin for whether to fight an infection, whether because they're coming to the surface for to attack a yeast or fungal hyphae that are growing there, whether they're coming in for a folliculitis, whatever the reason, remember that neutrophils come from the blood and they have to get out of the vessels and into the skin through diapedesis, the white cells crossing over the vessel wall. And in that process, you're going to see a lot of neutrophils clustered in the vessels and coming out of the vessels. So anytime you have a reason for neutrophils to be around in the skin, like an abscess or something like that, don't be surprised to see neutrophils coming out of vessels, and don't necessarily think that that means it's LCV. But when you do find fibrin in the vessel wall and you do find nuclear debris, and also it's a nice hint, you don't always have it, but oftentimes you're going to have red cells that are scattered out in the dermis, and they tend to be kind of trickling in between the collagen bundles like this, and they tend to be localized near the damaged vessels, so superficially. So this is a nice example of leukocytoclastic vasculitis. Again, look, here's a focus here. You can see even from lower power, there's the vessel lumen, beautiful layers of pink fibrin around it, and neutrophils and nuclear dust and red cell all extravasated out of the vessel there. So perfect example of leukocytoclastic vasculitis. So let's go back to lower power for a minute on this case and take note of something. This is a superficial shave biopsy. I'm really having trouble with the light here. Okay. And even though it's a little hard maybe to make out all the details, what you can tell is that the majority of the involved vessels and the inflammation is right up here in the superficial portion of the dermis. We don't really see the very deep dermis, but you can definitely tell that most of the inflammatory response around the vessels and most of the hemorrhage, everything is in the superficial layer of vessels near this, what we call the superficial vascular plexus. And this is typical of leukocytoclastic vasculitis that's confined to the skin. Now, some systemic forms can also just present in the superficial vessels, particularly Henoch-Schonlein purpura, which is an IgA-mediated vasculitis that occurs usually in young kids and can involve the GI tract and the kidneys as well. So this is a thing that you can't, I can't tell Henoch-Schonlein purpura apart from regular localized cutaneous LCV on H&E only. The way to tell that apart is by direct immunofluorescence and also the clinical symptomatology. So most of the time when kids have vasculitis, the majority of it is going to be Henoch-Schonlein purpura. So when there's a suspicion for that, our dermatologists will usually do a second biopsy and they'll put it in Michelle's media and they'll send it for direct immunofluorescence. Now, most types of regular LCV that we see often are going to have a C3, complement 3 deposition in the vessel walls, and also a lot of fibrin or fibrinogen surrounding the vessels. That's the typical pattern you see for most types of LCV. Now, there are a lot of other subtleties for different types of vasculitis, particularly the systemic ones, that we won't get into today. But when you're looking for Henoch-Schonlein, what you'll see instead, you'll see the fibrin and fibrinogen, but around the vessels in the vessel wall, you'll see subtle deposits of IgA. And I find that in my experience, most of the times when I see it, it's quite subtle, and you have to look really closely on high power around the vessels if there's any suspicion for Henoch-Schonlein to make sure you don't miss it. So right here we have a nice example of direct immunofluorescence performed on a case of leukocytoclastic vasculitis. And you can see this really bright layer of deposition around each of these vessels. The vessels mostly up here in the papillary dermis and along the superficial vascular plexus. And this is fibrin, and fibrinogen and fibrin will show a lot of deposition in the vessel wall and around the vessels, like you would imagine based on what we've seen on the H&E. And you can see even down in the deep dermis, there's some involvement of the deeper vessels here, and you can see blistering. So this is a case of bullous leukocytoclastic vasculitis, and the depth of involvement raises the possibility of systemic involvement as well. So this is a good example of what we see. I don't have a C3 picture handy, but it's going to usually be a lot more subtle, but you're going to see little granular C3 deposits in the vessel walls around these same vessels in a typical LCV. In Henoch-Schonlein, you'd see IgA granular deposits, very subtle around these vessels as well. Okay, so when we see vasculitis that is just superficial like this, that's the typical finding. But when we see it going deeper into the deep dermal vessels, if there's significant deep dermal involvement, we have to start thinking about the possibility of systemic vasculitis. And sometimes I'll actually specifically raise that possibility in my reports to make sure that the clinicians know to do additional workup. So here's one example of such a case. And you can see that definitely there's a lot of infiltrate up here in the superficial dermis, but it also extends down into the deep dermis and even starts getting into the little outcroppings of subcutis that we have here. And when we look closer, again, there are damaged vessels. Just like before, there are vessels here, and there's nice fibrin around them, neutrophils, and there's nuclear debris, little dust out there surrounding the vessels. So a really good example of the pattern of small vessel neutrophil-mediated vasculitis here. But we have also, when we go down deep, we can see that deeper vessels are involved too. And this vessel is relatively normal, but the small vessels around it have some damage. And it's going all the way down even down here. So deep dermal vessels, and even in the subcutis we can see that vessels have neutrophils around them. So that's one sign for systemic disease. And when neutrophilic vasculitis or leukocytoclastic vasculitis involves a lot of deep dermal vessels, you begin to get damage to so many vessels that you develop some ischemia in the skin. There's not enough blood flow, and the epidermis is particularly sensitive to making sure that it has enough blood flow. And when it does not get enough blood flow, it starts to die. And you can see here that there's so much neutrophil and fibrin deposition here that we're starting to get little bubbles underneath the epidermis, at the dermal epidermal junction there. And if we look over at a different piece, there it is, you can see in fact that the damage has become so robust that it's detaching the whole epidermis and making a blister. So we use terms like bullous leukocytoclastic vasculitis to describe this, when there's clinically blisters present, and this is what it looks like microscopically. Numerous vessels involved by vasculitis, usually deeper involvement in the deep dermis by vasculitis. Again, really nice example of a vessel with damage and fibrin and neutrophils and debris around it. And then up here you can see the epidermis is detached and there's numerous neutrophils both kind of infiltrating the detached epidermis and down underneath it here in the blister cavity and just below. So that's bullous LCV. And here's another example where the bulla has become so pronounced actually that it's made an ulcer with crust over top. Now let's take a minute to talk about ulcerations and about the lesions themselves, where and how you biopsy. So for those of you who are dermatologists or clinicians watching this, there's some important things to know about vasculitis. So if you're doing a biopsy for vasculitis, getting the most symptomatic, painful lesion that's red or purple looking, but also that's as early as possible, is the best thing, because over time, as the lesions of vasculitis age, sometimes the inflammatory infiltrate changes, and that can make it harder to tell what type of primary inflammation was there to begin with, if it was really neutrophils or not. The other thing is that if you get bullous lesions that then ulcerate, ulceration itself can recruit neutrophils and can cause a secondary underlying vasculitic change that's not really necessarily the primary process. We see this all the time in biopsy sites. When they go back to do an excision, we'll see vasculitis right where the biopsy site was. Or at the site of arthropod bites or excoriations, we'll see sometimes changes that look like vasculitis underneath. So my recommendation usually to our dermatology residents is to biopsy the most symptomatic, painful lesion that has reddish erythema or purpura to it, but try to get one that doesn't have an ulcer if possible, if there's any question about vasculitis in the setting of ulceration. The other thing is, ideally, it's good to get as deep of a biopsy as you can, at least down to the deep dermis, and ideally, if you're worried about one of the deeper forms of vasculitis that we'll talk about in a minute, down into the subcutis. So that the best, the most ideal situation is to do an incisional biopsy. That's not always practical, particularly in the clinic setting. Sometimes it can be harder to have all the things that you need or the time set into the schedule to get an incisional biopsy. So one thing that we've taught our residents that you can do in a pinch is to do what we call a double punch. So you do a punch biopsy down all the way as deep as you can into the dermis, pull that little core of tissue out and snip it and put it into the specimen bottle, and then go back into that same hole that you made with the first punch and use the punch tool and go down again deeper into the underlying fat and pull that up and snip that and put it into the same jar. And then you can just put on your requisition sheet that it's a double punch, in an attempt to get the subcutis. I've found multiple times where that's really been helpful, not only in the setting of vasculitis, but also if you're looking for a tumor that might be deeper, and also if you're looking for, say, calciphylaxis or some other process that generally involves the subcutis mostly. Getting a double punch is a good thing to do if you don't have the ability to do an incisional biopsy. So again, this is an example of bullous leukocytoclastic vasculitis that's actually ulcerated and ruptured. But why I'm showing you this is because look over here. This is what's happening before the rupture. You can see an enormous amount of fibrin, blood, and neutrophil debris filling up this space underneath, and it's making a blister cavity that's on its way to rupturing. And look at the epidermis. Even though this is a bit of an older slide that's washed out, if you compare, here's the normal epidermis, you can see that the washout is not actually from an old H&E in this case. The washout is these cells are losing blood flow and dying and degenerating. So this kind of kind of really pink, washed out, or kind of ghost-looking epidermis, this is what happens from ischemia. So anytime you see that change in the epidermis, you have to think something is blocking blood flow to the epidermis. And then you need to go find out, is it because there's vasculitis underneath? Is it because there's thrombi in the vessels? Is it calciphylaxis? Is there some other reason that the person has ischemia? So this is a good general pattern in DermPath. Recognize this pallor and pale pink change, and the nuclei are starting to kind of dissolve and wash out. These nuclei are still retained a little bit, but eventually they will all die and go away. And you can tell that this process happened relatively quickly because look, the corneal layer is still beautiful basket weave orthokeratosis, doesn't even have parakeratosis. There's nothing here to imply that this is a chronic process. It probably happened very quickly, and the epidermis didn't have any time to respond. It was just kind of killed in action by the loss of blood flow. And again, look down below, we can see that the problem here is not all the neutrophils and fibrin up here, but actually the involvement of multiple vessels down here. Because sometimes in leukocytoclastic vasculitis, in fact, relatively often, in addition to the vasculitis, in the lumen of the vessel, we'll start to see fibrin thrombi formation. So as the vessels get damaged, they kind of fill up and can become occluded by fibrin thrombi. So that's a good thing to keep in mind. Now, there are some systemic clotting processes and thrombotic and other vaso-occlusive processes that can have fibrin thrombi filling up the vessel, as well as leukocytoclastic vasculitis. So it's always good to keep that in mind and consider doing coag workup clinically, as well as other systemic rheumatologic serology tests that you need to exclude a systemic process. So when there's deep involvement, we think of systemic vasculitis as a possibility. When you see a bunch of EOs, you also think about systemic involvement. And when you see a lot of neutrophils out away from the vessel, the individual vessels, those can be signs also that you're dealing with a systemic process. Now, let's show a couple of other unusual variations on vasculitis here. So this is a nice example, again, of what I was showing you in the other biopsy. Let's see if there's any normal. This is relatively normal epidermis here. And watch what happens as we transition over. It totally ghosts out and becomes pale. Just like that last case, look what's happened. The epidermis is dying because of ischemia, loss of blood flow. The nuclei of the keratinocytes, they're still there, but they're not purple anymore, because as cells die and their nuclear membranes open up, the first thing to get broken down really is the DNA and the nucleic acids in the nucleus. And that's what makes the nucleus look purple on the H&E stain. The nucleic acids pick up the basic hematoxylin stain. The cytoplasm looks pink because it's filled with keratin filaments, as we talked about in my normal skin histology video. And if you look up above right now, you'll see a little link pop up, and you can go watch that video right there if you want to get an update on normal skin histology. And but what happens is that the nuclei break down first, and so you'll see the loss of the nucleic acid, so the nuclei don't look purple anymore. And then the cytoplasm still looks pink because those keratin filaments are big, strong, intermediate filaments, big protein bundles filling up the cytoplasm. It takes a long time for those to be eventually broken down and destroyed, so they actually are much more sturdy and will stick around even well after the tissue itself is totally dead. And again, look, there's nice orthokeratosis up top, almost no para or anything chronic here. This happened really suddenly. And so that's, again, the sign of ischemia, and you don't have to look far in this biopsy to see where the ischemia is coming from. Where was the piece? Ah, look at that. Look at these huge dilated vessels, and they're filled not only with blood. The blood's the bright pink stuff, but look at the pale pink smudgy stuff. That's fibrin, right? So we have fibrin not only just around the outside wall, but it's filling up most of these vessel lumen. Tons of fibrin, more fibrin, more fibrin. This vessel right here is almost totally filled. So the vessels are basically filled with clots. All of these are fibrin thrombi, or what we, the lay people would refer to as clotting. And this is also causing all the vessels to be damaged. There's blood leaking out, and there's hemorrhage, all sorts of red blood cells out in the dermis, and there's a bunch of fibrin thrombi filling these vessels and blocking blood flow. And if you look also, it's a little more subtle in this than in the previous cases, but these are not just fibrin thrombi like we'd see in any normal coagulopathy or clotting disorder. But actually, there's subtle leukocytoclastic vasculitis here. Let me try to find a good area to convince you. I think this will work. You can see the presence of nuclear debris. So there are some neutrophils, not very many, there's a few of them here, but you can also see debris in the damaged vessel wall. So it's not just fibrin thrombus, it's fibrin thrombi with neutrophilic infiltrate, even though it's subtle, and with cytoclastic nuclear debris from those neutrophils breaking down. When we see this setting here, we have to think about, again, about systemic vasculitides, and particularly some of the ANCA-associated vasculitis. You can see this finding, but in this case, there was a distinct clinical feature. These areas were bullous, or were almost bullous forming, and they were very purpuric, and they were on the ears, just the ears. So this clinical picture is actually really distinct. When you have purpura on either the ears or the nose, and that's the main area that you have purpura, and the biopsy shows neutrophilic vasculitis with a lot of thrombi, the diagnosis usually is Levamisole-associated vasculitis. And so this is kind of an interesting vasculitis that goes along with a clinical history. And a lot of times these patients will have positive ANCA in their blood, C-ANCA, I believe. And the reason that people get exposed to Levamisole is an anti-helminthic drug used for deworming livestock or animals in veterinary medicine, if I understand correctly. But it's also, it makes its way into humans because it gets mixed into cocaine powder that's sold on the street. So it's used as a cutting agent or a filler to expand the amount of cocaine so the people selling it can make more money. But the problem is that it causes this systemic vasculitis that can be pretty problematic for patients. So whenever that clinical comes up, and when you see this finding microscopically of these vasculitis with a bunch of thrombi in them, always think about Levamisole, and the clinical history and a drug screen clinically can be useful to help figure out if that's really what's going on here. So if you don't think of it, if they run a C-ANCA and it's positive, it can get confused with other ANCA-associated vasculitis, which often have systemic involvement, and that's not good. So it'd be good to figure out that this is actually drug-related. Okay, here's another thing that has a little bit of a similar appearance microscopically. That's a funny cut where the tissue is embedded a little bit funny, but here, that's the normal. And this, the epidermis is completely eroded or ulcerated away. And so I told you have to be careful in that setting, but sometimes you will see vasculitis where there's just ulceration over top. And that's all a bunch of crust up there, or scab, basically a bunch of fibrin and neutrophil debris. And underneath it, though, you can see lots of vessels here, and the vessels are dilated, and they're filled with pink material. Now, at first glance, this might look like fibrin. And in fact, some of it probably is fibrin. But in addition to fibrin, some of it, and you can see kind of these little islands of it floating here. Let's see if we can get closer. You can see there are neutrophils are in and around the vessel, but these pink areas here, they're really kind of a bright pink. I'm not sure if it shows up well on the video as it does microscopically, but they look kind of a brighter pink and more homogenized and kind of glassy looking, or hyaline looking, we say. Hyaline means glassy. But this material is actually cryoglobulins. This is cryoglobulinemia, what we call mixed type cryoglobulinemia. So there are three main types of cryoglobulinemia, and these are caused by different immunoglobulins that are making deposits in the vessels. So type 1 cryoglobulinemia just has cryoglobulin deposit in vessels with no vasculitis. Types 2 and 3 cryoglobulinemia are called mixed because they have not just one immunoglobulin, but a mixture of at least 2 different immunoglobulins, and you can do some reading about that. Some of them are rheumatoid factor. There's a lot more complexity to cryoglobulin than we're going to go into today. But the type 2 and 3 mixed cryos have not only cryoglobulin and fibrin thrombus filling up the vessels, but also have neutrophilic vasculitis. So when you see LCV with a lot of what looks like fibrin thrombi, always keep cryoglobulins in your differential. And in fact, anytime I see what looks like thrombi filling vessels, either with or without vasculitis, I tend to like to put a comment to make sure that cryoglobulinemia is excluded. Usually though, you can kind of suspect cryo because it looks, like I said, more dense pink, and it's kind of glassy. And if you're lucky enough to get an immunofluorescence with it, it will actually stain differently. You'll see fibrin stains in the background between these deposits sometimes, but the deposits themselves that will light up either with IgM or IgG, depending on whether you have type 2 or 3 or what type of deposits you have, what kind of cryos you have. So I think this is a really nice example. And this other piece, let's look at the other piece over here. Where did it go? This one, even though it's cut funny, you can see, look just how dense and pink and bright the cryoglobulins are, and they actually light up on PAS stain usually. So doing a PAS stain will sometimes help show, will show the cryos, and also if you have an IF. And of course, clinically, they can draw blood and test for cryoglobulins through some specific laboratory testing that can be done. So a nice example of mixed type cryoglobulinemia, which also gives you a neutrophilic vasculitis. The vasculitis is much more subtle here, but there is vascular damage and there are neutrophils around the vessels. Here's an example of that same case of cryoglobulinemia, and you can see that the deposits inside the vessels are bright pink on the PAS, periodic acid shift, PAS stain. So the PAS is highlighting the cryo material that's depositing inside the vessel lumens. You can see it here, here. It's really nice, very, very dense on H&E, and very deep, bright pink staining on PAS stain that can kind of help you to distinguish it from background fibrin, which will also pick up PAS to some extent, but I feel like the staining is much more intense on cryoglobulins. So sometimes I'll use PAS in cases where I'm suspecting cryo, but I still often suggest that they correlate with the blood studies and also the clinical picture to be sure. Here is an example of the direct immunofluorescence from that same case of mixed type cryoglobulinemia. And what you can see in this case, mixed type cryoglobulins, there's type 2 and type 3, and there's a variety of mixtures of antibodies that can be deposited in the vessel. In this case, what we had was IgG, which you can see is filling up the vessel here. These sparks and the little specks in the background are some background staining in the epidermis. But you can see the vessels, the deposits in the vessel are staining here with IgG and very brightly staining with IgM. And I believe in this case the patient actually had rheumatoid factor in the blood, and so this IgM is IgM with a specificity for IgG. So IgM that's called IgM anti-IgG, that's rheumatoid factor. And so in some cases of mixed type cryoglobulinemia, the deposits actually have rheumatoid factor in them. So we had both IgG and IgM present here in the vessel spaces in this case of mixed type cryoglobulinemia, which is a really nice example of how it's supposed to work. Now we said that if you see deeper involvement, to think of systemic disease, if you see EOs, if you see granulomas, which we haven't showed anything with granulomas yet, but those things can all make you think of systemic disease. And most of the vasculitis, or all of them that we've looked at so far, focused on the superficial or superficial and deep dermis, really. But this is a case where most of the inflammatory action is going on at the dermal subcutis junction, or even within the subcutis. And it's all centered around one big dilated vessel here that's been basically totally destroyed by vasculitis, by inflammation. So this was a vessel, and it's got blood and a bunch of fibrin. Here's the fibrin, this is the blood. You can tell the difference. Fibrin and blood sometimes are hard to tell apart, but usually you can tell because fibrin is a lot more pink than blood. So the fibrin here at the top, much more pink and smudgy looking and kind of smooth and homogeneous. And the blood is a brighter red color. And also when you go to higher power, and if you flip the condenser too, you can see it better, I think. You can see that the blood's still made of individual red cells. So I think if you're having trouble, especially, it's kind of easy to see in this case, but if you're having trouble telling blood from fibrin in vessels, which I think is hard at first when you start doing a dermatopathology, you can flip your condenser and you can look closely to see if you can see individual red cells filling up the space. That's probably just blood, and if you see more of this pink smudgy stuff, it's probably fibrin. And then look out around here, tons and tons of neutrophils, which have basically replaced and totally damaged the vessel wall. And there's also a lot of reactive change in the adjacent smaller vessels. They've got a lot of fibrosis and edema around them, and kind of thickening of their vessel walls, so they're damaged as well and reacting to all this inflammation. So when you see a large, or a kind of what we call a medium size, it's large by skin terms, but compared to the rest of your body, it's not really that large. So we call these medium-sized vessels, and they usually have a muscular wall. So a medium muscular vessel, they are almost always in the deep dermis or the subcutis. You don't see vessels this big up in the upper parts of the dermis usually. And when you have inflammation like this destroying that vessel, this is a classic example of polyarteritis nodosa, or PAN, P-A-N. And so in fact, whenever I see fibrosis and inflammation that's limited to the area right around the dermal subcu junction, I always think, could this be PAN? Especially if they're describing painful, tender, nodules clinically. I'll go and cut deeper levels and look to see if we can find any lesion like this that would represent PAN. So clinically, usually the dermatologists are very astute on picking up on PAN because it's these painful, tender nodules. And there are other things like paniculitis that can have that presentation. And I think I forgot to mention it, that most of vasculitis, the most common site that we see it is actually going to be on the lower extremities, on the legs. It can arise in other places, and particularly with weird things like the Levamisole, like I told you, that's going to be the ears and the nose. But most of the time when we see leukocytoclastic vasculitis, it's on the legs. And here's another one. Beautiful example. The upper portion of the dermis, the epidermis, looks basically normal. But when you get down here at the junction of the dermis and the subcutis, you see a medium-sized muscular vessel that's totally inflamed. So it's not quite as advanced as that last one I showed, which has destroyed the whole vessel. Here you can actually see very beautifully, you can see the multiple layers of muscle in the media, the medial layer of the vessel wall, and you can see all these neutrophils that are just destroying the muscular wall. So you can see a little ring of muscle still around on the outside. You can see a little ring of the muscle here, and then in the middle, tons of neutrophils kind of chewing up that vessel wall. The whole lumen is packed full of fibrin and a little bit of red cells and probably a few endothelial cells that are trying to recanalize and repair the vessel, and neutrophils as well. So nice example of polyarteritis nodosa, and oftentimes these patients will have systemic internal organ involvement, so additional workup is going to be needed to exclude that possibility clinically. So that's a beautiful, just classic example of polyarteritis nodosa. All right. Now, I apologize, this is a faded biopsy. This is not ischemia. This is just an old H&E stain, but this is something that I don't see very often, so the only one I have to show you is an older example. So here the vasculitis, there's a lot of inflammation, but the damage of the vessels is relatively subtle. Another thing that kind of helps me sometimes if I'm struggling to tell if there is vascular damage is if there's clinically evidence of purpura or erythema, like if there are lesions that look red and purpuric like vasculitis. So if I think I see some hemorrhage or some stuff that might be vasculitis microscopically, but clinically they don't think it looks at all like vasculitis, it doesn't mean that it couldn't be vasculitis, but it really makes me hesitant to be definitive about a diagnosis of vasculitis, because usually clinically they're pretty astute on suspecting vasculitis. The dermatologists are. They have a lot of experience with this. There are some times where vasculitis is suspected clinically and microscopically we don't see it. We see other things causing hemorrhage or thrombus, and that's a different story. But the converse is not true. When there's no evidence clinically, when the skin doesn't look like vasculitis, it's very unusual that I'll see true vasculitis microscopically. So here, the vessels, the damage to the vessel is really very subtle. You don't see much fibrin or anything, but what you do see is numerous eosinophils in addition to neutrophils that are spilling out of the vessels. It can be hard to tell apart neutrophils and eosinophils microscopically, and even harder, I think, on YouTube. But I think one thing you can do is going down to high power, if you look and you see just 2 lobes to the nuclei, bilobed nuclei, they look like little sunglasses maybe, that's going to be an eosinophil. If you can see 3 lobes or more, then those are going to be neutrophils, okay? So they have like more lobulated nucleus, for one thing, to be a neutrophil. Neutrophils also have orangey looking cytoplasm like eosinophils. It's not quite as bright orange, and even though neutrophils do have little granules, the granules are so small that you can't see them even on 40x. You have to use like oil immersion lens to see the granules in neutrophils. But eosinophils, the granules show up very nicely, and on this video it's hard to see them, but when you flip the condenser, you can start to pick up. Let's turn the light up a little bit. You can pick up these guys down here. Look at all those little granules granules and little aviator sunglasses there. Those are your eosinophils. And you can see that those guys I was pointing at there, they don't have those granules. So that's how you can tell eos and neutrophils apart. And also sometimes lymphocytes or neutrophils sitting on top of red blood cell in the section can look like an eosinophil. So those things are there to keep our life interesting while we're trying to look around microscopically and figure out what the cells are. So when you see a vasculitis with tons of eosinophils, you should think of a couple things. One, you can think of a drug-associated vasculitis. So lots of things can cause vasculitis. Drugs, some infections, and like I said, a lot of different systemic diseases, including lupus and connective tissue diseases. All of those things can cause vasculitis. So just because we see vasculitis doesn't mean we know what's causing it. And that's kind of one of the challenges, I think, for the dermatologist and the rheumatologist to figure out what the cause of the vasculitis is. But when we see lots of EOs, we can think of drug-associated LCV, and we also can think of Churg-Strauss syndrome. So Churg-Strauss, or allergic granulomatosis, is the other name for it, I believe, is going to be usually going to give you a leukocytoclastic vasculitis, and often there are numerous eosinophils, and sometimes those eosinophils are so numerous that they break down and make kind of these red pools of eosinophilic granular debris that are kind of making granulomatous type structures. So they look kind of like granulomas loaded with eosinophil debris. And they're kind of called red granulomas is one name that's sometimes given to them. So when you see we don't have them in this case, unfortunately, but when you see those, that's one really good sign for Churg-Strauss. But in fact, the couple of cases I've seen of Churg-Strauss most recently did not have anything like that. It just looked like LCV with lots of EOs, or in this case, the vasculitis is really not you can barely even see any vascular damage, but tons of EOs. And a clinical workup, though, for Churg-Strauss is worthwhile. So I think the most recent one had good LCV, but it went deep into the dermis and had a lot of EOs. I don't have that slide handy for some reason, but that one actually I mentioned to the dermatologist to do further workup, and in fact they did find Churg-Strauss after they worked the patient up. So it's good to make those kind of comments. Sometimes that can really help in the dermatologist figure out how to better manage the patient. So think of drugs, and think of like medication drugs, not necessarily cocaine or street drugs, but think of medication-associated etiologies, and also think of Churg-Strauss when you see lots of eosinophils present in the biopsy. Now this is a really fun entity that I really like. This is a shave biopsy of a violaceous plaque on the face of an adult. And you can see the dermis has a lot of inflammation. Basically, the whole dermis is kind of packed full of inflammation, but the epidermis is totally spared. There's no inflammation or really any change of the epidermis. And there's a little zone of relatively normal dermis between the inflammation and the epidermis. So people call this in dermpath a Grenz zone. And the Grenz zone I find to not particularly be a very useful concept, because a lot of things that are supposed to have a Grenz zone don't always have it, like dermatofibroma, for example. But in this particular entity, I think the Grenz zone actually is useful because it's almost always there. There's a bunch of inflammation in the dermis, but then there's this little thin layer of normal separating the epidermis, which is totally uninvolved, which is surprising for as much inflammation as there is in the dermis, that you really don't have very much change at all to the epidermis. And when you go down closer and look, what are these inflammatory cells filling the dermis? You see a variety of different cell types, which is also unusual. You can see here lots of eosinophils, histiocytes. So here's the histiocytes, these guys in here. There's the EOs with their little sunglasses, a little bilobed nuclei. And also look at these, neutrophils, scattered neutrophils. Not like forming an abscess or anything, but just kind of scattered in with these EOs and with these histiocytes and also some lymphocytes. And somewhere around here, there they are, plasma cells. So when you see a dense infiltrate with all this mixed inflammation, EOs, neutrophils, plasma cells, lymphocytes, histiocytes, and it's making a violaceous or erythematous plaque on the face, this is called granuloma faciale. And notice one thing that we did not see here. No granulomas. So this is one of the many, many misnomers in dermatopathology and dermatology, something that's called granuloma that actually has no granulomas. So if you see actual granuloma formation, I mean, you can have histiocytes kind of scattered in here, but if you see well-formed granulomas, it's probably not granuloma faciale. So G faciale or granuloma faciale is this mixture of all those inflammatory cells, and it's usually on the face. At least that's the only place I've ever seen it. I'm sure someone's described it elsewhere, but the only place I've seen it is the face. So why am I showing you this in a vasculitis video? Well, let me find the area. Now, of course, I've probably lost it. You can begin to get some vasculitic change in G faciale. So here, the vessels, you can see the endothelial cells there, and you don't see a bunch of vasculitis, but you do see some neutrophils around the vessels. And at closer look, you do see some fibrin. Let's see if I can keep it here without having jittery hands. There we go. Some fibrin and just a little bit of nuclear dust, those little purple dots. So there is some subtle leukocytoclastic vasculitis change in here. And that vasculitis can vary, and it can be really focal. Here's another little vessel that looks like it's got some neutrophils around it just a little bit. Here are a couple other vessels surrounded by both EOs and maybe a few neutrophils. And it can, and there's a couple more. So you can have a little bit of vasculitis in this process, and sometimes it actually can be quite extensive and can even begin to get kind of sclerotic and fibrosing. Let me show you another example of that. So this is also from the face. Oh, and I dropped the slide. It's bound to happen whenever you're recording a video. And here, this is a punch biopsy. And on this one, actually, the vasculitis is much more apparent. Each vessel is really surrounded by a lot of fibrin and a lot of neutrophils. And additionally, you can begin to see kind of this swirling layering effect. See how there's kind of a spiral of swirly deposition of not only fibrin but also a little bit of collagen and some spindle cells that are starting to kind of wrap the vessel in what people kind of say an onion skin pattern. We use the term onion skin way too much in pathology, but it really does start to look like that. Here's another one. Here's a vessel that's got fibrin and neutrophils, and it's kind of got this swirly wrapped pattern. In the background, you can still see the plasma cells, you can still see EOs, you can still see that Gren zone separating the epidermis from the dermal infiltrate. So it still fits nicely for granuloma faciale, and clinically it did too. But this is a good example that in G faciale, sometimes you can have what's called a fibrosing vasculitis or fibrosing vasculopathy with neutrophils. And the reason that this is kind of interesting, just to recognize the pattern, but also because there's another entity that has a very similar thing. And in fact, now there are a variety of things that can sometimes have this same pattern. But there's another particular disease in Dermpath that has this, and it's called Erythema elevatum diutinum. That's a long name, right? So we call it EED, so we don't have to say that all the time. EED, or Erythema elevatum diutinum, also has a fibrosing vasculitis, just like we saw there in that last case of granuloma faciale. The difference in EED, though, is that it's usually on the hands, the feet, sometimes the elbows, and it makes these kind of larger. They can be erythematous red or violaceous, but they're kind of larger, firm nodules. And the reason is because in this entity, there's a lot of fibrosis. So in the primary process, my understanding is that the primary process is that you still have a neutrophilic vasculitis, but it leads to so much sclerosis and fibrosis that kind of swirls around it that the vessels that are actually damaged get really trapped, and it's actually hard to see them. I'm trying to find some good areas. Like here, it's hard to even see that there used to be a little vessel in here, and it's swirled and wrapped around by fibrosis, and then the background is totally dense sclerotic collagen. And again, just like in G faciale, the EOs are present, scattered around, and again, you can see there's some neutrophils here and some nuclear debris as well. So it's like a subtle LCV that's kind of burned out and left behind an enormous amount of background sclerosis and collagen deposition that's basically filling up the dermis and down into the subcutis. And so that's why it makes these nodules that are seen clinically. This is really rare, at least in my experience. I've only seen a couple cases of EED. It's a very uncommon thing. G faciale is relatively more common from what I've seen. So again, here's a vessel that's kind of left over in here. A couple vessels, actually. You got like two little lumens together, and some neutrophils and debris around it, EOs, and then tons of background sclerosis. And I've seen similar changes to this also, going back to cocaine, not in people, not because of Levamisole, but actually from people who nasally inhale or snort cocaine powder. Sometimes that chronically, we've seen cases where chronic cocaine snorting has led to this sclerotic, fibrotic vasculitis within the nasal cavity. I've seen a case or two where that was thought to be the cause of the similar thing. And again, Andrew Carlson has written papers about how this pattern of sclerosing vasculitis with neutrophils is seen in other things outside of G. faciale and Erythema, elevatum, diutinum. So not everything with that is G. faciale or EED, but I think it's good. Those are both classic dermpath entities, and it's good to know about those. And let me show you another example of EED. This one not quite so extensive and dramatic. Let me turn it around so it's the right side up. Not quite as extensive as the last case, but you can see there's like a nodule down here. This slide is a little faded, but it's a really good example of that kind of onion skin fibrosis that you can see. Lots of small vessels trapped in here. These little plump cells, these are actually endothelial cells. So these are tiny little vessels that are so compressed that you can't even see the lumens anymore. And they're surrounded by layer after layer after layer of not fibrin, but actually collagen. This is collagen wrapping around and sclerosing around the vessels. There's proliferation of multiple small new vessels, and they're all getting trapped up in this collagen. And then there's also lots of neutrophils trapped in here. So again, this kind of almost could have like kind of a wood grain pattern or a multi-layered onion skin pattern of fibrosis surrounding little tiny vessels. Here's a few more vessels here that are standing out that have kind of survived but are still wrapped densely in sclerotic collagen. And so this is great for erythema elevatum diutinum in the right clinical setting. And also look up here, what do we see? Leukocytoclastic vasculitis. Here's where it starts. It starts with a vessel, fibrin around it, neutrophils, neutrophil debris. So we're back to where we started at the beginning of the video. So I hope this gives you at least a brief overview of vasculitis and dermpath. And again, it's a topic you could spend your whole career, I think, focusing on and writing about and reading about. And it's such a huge topic. And I encourage you to use this as a starting point and then go and do some reading on your own.